Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi taala wabarakatuh. Inshallah we start our discussion with Ulumul Kitab Al-Fatihah. Alhamdulillah. So inshallah today we will discuss about topic clinical application of radiopharmaceutical. Before we proceed to the application of radiopharmaceutical, I would like to share with you some history of imaging. So 1895, the first film X-ray been taken by William Conrad Röntgen, and then 20 years after that, hot cathode X-ray tube been invented. So this hot cathode X-ray been used in all low dose imaging like CT scan, radiograph, and then 60 years after that, Hall Engel invented gamma camera. So this gamma camera that we use for nuclear medicine study. And 1956, ultrasound be introduced by obstetric and later being used in other system by radiologists. And in 1960, invention of positron emitter detector. So this is another instrument that we use for nuclear medicine study. So if you see here, before 1970s, there are three main modalities that can be used for imaging to help for diagnostic purpose, which is X-rays, radiograph, we have nuclear medicine study, and also ultrasound. And then later in 1970s and 80s, late 70s, CT scan and MRI be introduced. So what is nuclear medicine? It is a branch of medicine, and as you know that nuclear facility you also use in other fraternities such as agriculture, military, industrial, so research. So this is a part of the branch of medicine, and it uses radioactive. So if you compare to radiology, the X-rays is the radiation is emitted by the machine itself. But for nuclear medicine, we use a radioactive, then we inject to the patient, then the patient itself will emit the radiation and detect by the instrument that we have, which is either gamma camera or positron emitter detector. And then for functional and anatomical information, so it will give this nuclear medicine study will give a functional and anatomical information. I put functional first because we are more focused on functional information rather than anatomical, and it will give the beautiful functional information. If you want the anatomical information, usually we use a CT scan or MRI. And that lastly for diagnostic and therapeutics. Okay, so we continue our then type of ionizing radiation, machine generated X-ray, low photon energy, usually used in radiography, CT scan, mammogram. So it use a conventional radiology used by the radiology. And if you use a high photon energy, teletherapy, radiosurgery, and it put under oncology. And then we have a sealed or solid source of radioactive. For example, cobalt 60, cesium 137. So we use for radiotherapy to kill the cell cancer. And then we have third source of ionizing radiation, which is unsealed source, which is in the form of fluid and mostly used in a nuclear medicine fraternity. So we use for diagnostic and also for therapy. Okay, so nuclear medicine consists of a clinical part, radiopharmaceutical part, and nuclear pharmacy. As you know, the clinical part, they are diagnostic and therapeutic and interventional. So I will touch only some of the radionuclide imaging. because I think the non-imaging, Dr. Isa already touched some of the radionuclide non-imaging. So I only concentrate on the radio imaging, which is planar and PET. And then for your info also, we use for therapeutic purpose. I will show some example of therapeutic purpose for radiopharmaceutical in nuclear medicine. And then because this three fraternity is very important, because clinical part usually taken, you want to the clinical part, you want to see the use of this nuclear medicine study, and the radiopharmacy to make sure that all the labeling technique, all the radiopharmaceutical being prepared accordingly before we inject to the patient. And nuclear physics is important to make sure that there is no contamination or any radioactive spill in the department, and to make sure that if the patient vomit or patient urinate, they have to take care the exposure of radiation in the department itself. And then this is a principle of radiopharmaceutical preparation. Okay, so I think you already learned about the source of radioactive. We have three, actually two, which is what we call a primary source and secondary source. So the primary source of the radioactive is from nuclear reactor and also cyclotron. And the secondary source of radioactive is from the generator. So because like in quantum we don't have nuclear reactor, we don't have cyclotron, so we have to buy the generator system. So this generator system, I think you already discussed with other lecture. And then this generator system that we use, commonly used, is a molybdenum technetium generator. The principle, I think they also already discussed, and you should know the principle behind the generator system. So the most common radiopharmaceutical that we use in our department is technetium 99M. So this generator, molybdenum technetium generator, we have what we call a process of elution to get the technetium 99M from the generator. And then when we have the radioactive material, technetium 99M, we have to do some QC, quality control, to make sure that aluminium and also molybdenum are not in the high quantity in the elution. And then if the quality control is passed, then we have to select the pharmaceutical product. So this pharmaceutical product is a non-radioactive product. Why we choose, we have to use the pharmaceutical product, because the radioactive that we use actually are not specifically go to all organ that we want to image. So like technetium 99M, the physiological uptake of tracer is only in the thyroid, salivary gland, in the stomach, and it will be secreted in the bladder. So if we want to visualize or image the brain or heart, we need this pharmaceutical product as a carrier, or transporter to bring this radioactive to the organ or specific system that we want to image. And then we have mixture of we have to mix the radioactive and also pharmaceutical, then we call it radiopharmaceutical. And it will undergo a certain quality control to make sure that the amount of labeling or the amount of mixture of this radioactive and pharmaceutical is more than 90%. And if it is okay, then we'll calculate how much the activity that the patient need, and then we dispense and inject to the patient, either inject or give orally to the patient. Okay, so radiopharmaceutical, sometimes you read the book or you read the journal, you can see there's what we call other name of radiopharmaceutical. Sometimes they say a radio tracer, diagnostic agent, label tracer. So this is all the same meaning with the radiopharmaceutical. And then there are certain other diagnostic agent that can be used apart from technetium 99M, which is iodine 131, iodine 123, gallium 67, gallium 68, indium 111, lutetium 177, and we also have quite a number of the therapeutic agent, radiopharmaceutical, which is iodine 131, yttrium, samarium, strontium, phosphorus, and lutetium. So the most important, I think that I will introduce to you the only three. I will show you the three, maybe some of the example common radiopharmaceutical that we use in nuclear medicine study or imaging. First, the common one is a technetium 99M. I told you it emits a gamma emitter, and then energy is about 140 keV, and half-life is about 6 hours. Why is important of half-life? I think we already discussed with other lecturer. Half-life is important to make sure that the activity in the body is reduced accordingly. Meaning that when we know that physical half-life 6 hours, meaning that when we give the patient 10 millicurie of activity, it will be reduced decay, or it will be reduced decay. After 6 hours, it become 5 millicurie. So after 6 hours, it become another 2.5 millicurie. So generally, all radioactive have the physical half-life. It depends on each half-life. So usually we want the half-life is just slightly longer than the procedure that we want to do. Okay. So the second common radioactive radio tracer that we use is iodine 131. It can be used in therapeutic and diagnostic. So that's why we call it theranostic agent. So sometimes we will hear about this theranostic agent, theranostic treatment. So when they put theranostic, meaning that the same or the same type of the element or the same properties of element can behave or can be used for therapeutic and also for diagnostic purpose, because it have a beta and gamma emitter. So beta for the therapeutic and gamma for the diagnostic, and energy is quite high, 360 keV, and half-life is about 8 days, and mostly we use iodine 131 for therapeutic purpose. And then the last one, the most common radioactive or radiopharmaceutical that we use is fluorine 18. So this fluorine 18 is a positron emitter, which is produced by the cyclotron, and we take, or the pharmaceutical part is a fluorodeoxyglucose. So the fluorodeoxyglucose is mimicking a glucose metabolism uptake in the body. So we have fluorine 18 FDG. If you go later in your career, if you go to the nuclear medicine department, this is one of the most important positron emission radiopharmaceutical for the imaging, oncology imaging. So half-life is about 110 minutes. So usually you should the facility that want to do this positron emitter or tomography must have a cyclotron nearby or inside or nearby, because the half-life is about less than 2 hours. And we also have other positron emitters such as oxygen, nitrogen, carbon, but in our country mostly we use a fluorine 18 FDG. Okay, so nuclear medicine study, we will talk about imaging. I will share with you some of the imaging study in nuclear medicine using technetium 99M, iodine 131, and also positron emission tomography. So I will not touch this non-imaging, and I'll show you some of the image of therapeutic purpose in thyroid carcinoma using iodine 131. Okay, it also have interventional purpose, but we only discuss more on imaging. Okay, for general contraindication, mostly pregnancy we didn't do for patient which is pregnant, unstable patient, meaning that patient is all the vital sign is not stable. Usually, especially patient in intensive care unit, and then uncooperative patient. So uncooperative patient also, for the adult we usually didn't do the this is all not the absolute, this is a relative contraindication. But for pediatric patient less than 7 years old, usually we have to give the what we call sedation to when we want to do a nuclear medicine study. And these are the common nuclear medicine imaging that usually we do in the department. We have a bone scintigraphy, which is comprised about 50% of nuclear medicine study, and then we have a genital unit tract study, dynamic renal scintigraphy, renal cortical scintigraphy, and direct radiocardiocytography. We have a GIT in the intestinal tract, hepatobiliary scan or HIDA scan. We have medical scan or GIT bleed scan. And then I will share with you some of the lung scintigraphy, myocardium scan or myocardial perfusion imaging, and then some of the endocrine imaging that we usually do, thyroid scan, parathyroid scan, and some of neuroendocrine tumor scan, and then share with you some image of positron emission tomography and some example of the therapeutic application in nuclear medicine imaging. So general pre-procedure preparation, generally patient don't have to fast, but a certain procedure they need to fast at least 4 to 6 hours. It depends, but generally most of the study we don't patient don't have to fast. And usually prophylactic steroid is not necessary if patient having a history of allergy. If you go to the radiology department, if you want to do a contrast study, you need, if you have the allergy history of allergy either to seafood or any history of allergy, usually will cover you with prophylactic steroid for at least 2 days. So for nuclear medicine study, most of the study usually we don't have to prepare for the prophylactic steroid. Okay, bone scintigraphy, we go to the first imaging, nuclear medicine imaging. The indication for bone scintigraphy is to look for the bone metastasis, especially patient with cancer, primary cancer, and then metastatic to the bone. And we also can use to detect a primary bone lesion, and sometimes we can detect what we call bone infection or osteomyelitis. So if you see here, the radiopharmaceutical that we use is a technetium 99M methylene diphosphonate. So this technetium 99M is a radioactive, and methylene diphosphonate is a pharmaceutical product. So it is important that all the pharmaceutical product that we use, the carrier or transporter that we use, will mimic or will follow the physiological uptake of normal, in this study, normal calcium phosphate uptake in the bone. So if you see here, the uptake of the radiopharmaceutical will depend on the rate of bone formation. So if you go back to your physiology of the bone uptake of the calcium and phosphate, you will see that there is a osteoblastic activity and remodeling. So this normal physiological will maintain the integrity or the strength of the bone. So it will follow rate of bone formation. As you know, the cancer cell in the bone, it will multiply more than 4 to 8 times compared to the normal bone cell. So it will have a more increased osteoblastic activity, and then we will see that more increased radiopharmaceutical that will be uptaken in that area. And then the second factor is blood circulation. If there is no blood circulation, there will no uptake. And then the type of lesion or malignancy. If I list that, the prostate, breast, lung, thyroid, and renal is the most common cancer that like to go to the bone. So mostly prostate and breast will show as a osteoblastic activity, osteoblastic type, but lung, thyroid, and renal will show osteoclastic type of activity in the bone scintigraphy. So this is a bone scintigraphy. If you see, this is a whole body scan of bone scintigraphy. You only see the bone. So usually we inject the radiopharmaceutical or technetium 99M methylene diphosphonate MDP to the patient, and later after 2.5 hours, because we have to wait for the radiopharmaceutical to be uptake in the bone about 2 hours, and then we'll do the imaging. So the image will image the bone anteriorly, anteriorly and posteriorly. So if you see here, you will be see the increased uptake in the joint, mild increased uptake, because joint have a movement, so the osteoblastic activity is more in the joint. And then you see a renal and also a bladder. So this is the excretory part of the radiopharmaceutical. And then you will see this is sacroiliac joint, so this is normal. All this is abnormal. The joint will have a more uptake than the other non-joint bone. And you see here in the scalp, in the vault, it is slightly increased uptake because there is an overlapping of the bone in the scalp. And you see here at the pelvic, and then this is our normal bone scintigraphy. And this is also bone scintigraphy in teenager or less than 18 years old. Less than 18 years old, your growth plate is still active. So that's why there's a lot of osteoblastic activity. Then you will see the tracer uptake inside the growth plate. And then this is a bone scintigraphy. If you see here in the lower sternum, you see there's a decreased uptake of the radioactive. Okay, so like I said that some the lesion could be osteoblastic activity and osteoclastic activity. And this is the full blown of the bone metastasis, which is increased uptake in the a lot of body with patient with prostate carcinoma. And three-phase bone scan to detect the osteomyelitis. So the three-phase bone scan, we use the same technetium 99M MDP, methylene diphosphonate, but after we inject the patient with the radiopharmaceutical, we do a perfusion phase, and then later after 5 minutes we do a blood flow phase, and then after 2.5 hours we do a normal bone phase. So this phase we do to see the increased uptake in the region that interest, the one that we suspect infection in the bone. So we want to differentiate between osteomyelitis, bone infection, and also cellulitis, just inflammation of the soft tissue. So if we see the three positive in this positive image, meaning that all the image are positive, meaning there is an uptake, so meaning that it has an infection in the bone. So in despite of the if the cellulitis, meaning that the soft tissue inflammation, there will no uptake in the delay or bone phase. Okay, we go to the GUT, dynamic renal scintigraphy. So dynamic renal scintigraphy, we used to detect indication to look for the urinary obstruction and to assess a renal function and relatively quantify a renal function. And also we can use to calculate the glomerular filtration rate. So there are two main radiopharmaceutical that can be used. The first one is technetium 99M diethyl triamine pentacetic acid or DTPA, or technetium 99M mercaptoacetyl triglycerin or MEC3. So this is the common radiopharmaceutical that we use in dynamic renal scintigraphy. So I want you to just to find what are the pro and con advantages or disadvantages of the technetium 99M DTPA versus technetium 99M MEC3, and I will share the answer later, inshallah. So this is the image of the dynamic renal scintigraphy. Sometimes they call after the radiopharmaceutical. Just as this one, we use a DTPA, a technetium 99 DTPA. They say a renal DTPA scan. If you use a technetium 99M MEC3, they will say renal MEC3 scan. So this is what we call a dynamic image, meaning that we take the image on a real life. So when we inject the radioactive, then we simultaneously we start the image. So it will run like what we call like a movie, about 40 minutes. So we see the abdominal aorta, and then we see the nephrogram uptake in the renal, and later we see the excretion at the medullary part at the pelvic system, and then we see the ureter excreting in the bladder. So this is the renal dynamic renal scintigraphy. So we want to see the function of the kidney, if there is any obstruction at the level of PUJ or pelvic junction or VUJ, vesicular junction, and also we can detect, calculate the glomerular filtration rate by drawing the region of interest in the workstation. Okay, this is an example of the dynamic renal scintigraphy. If you see here, because we take it from posteriorly, so this is the left side of the renal, this is the right side of the renal. So if you see here, from the beginning, there is no uptake into the left kidney. So the left kidney is non-functional, but the right kidney taken the radioactive and excreted into the bladder. So we can actually locate which kidney is non-functioning, and it is important for the management for further management of the urology team. Okay. Renal cortical scintigraphy. This is another renal imaging nuclear medicine study that we do to look for the cortical uptake only. So the indication usually the pediatric patient have a recurrent UTI, vesicular ureteric reflux or pyelonephritis. So to assess the cortical function, if you go back to the physiology, the kidney can be divided into cortical part and medullary part. So the cortical part is a functional unit of the kidney, and the uptake of the tracer will go only into the cortex of the kidney. So the radiopharmaceutical that we use is a technetium 99M dimercaptosuccinic acid, which is the DMSA. So this is a renal cortical scintigraphy, or sometimes they call renal DMSA scan. So you take a static scan, we inject the technetium 99M DMSA to the patient, and after 2 hours we take this image. So we take the image anteriorly, posteriorly, and 4 oblique view. So you see here, there's very nice shape of the kidney. You see if there is any defect in its scarring, and then we will see the decreased uptake at a certain pole or certain part of the kidney. Okay, this is another example of the dynamic renal cortical scintigraphy, or the DMSA scan. So if you see here, if you take the anterior view, right anterior oblique, so you see that the left kidney is, the uptake in the left kidney is decreased, or you can see that there's a faint uptake on the left kidney, but the right kidney show a good tracer uptake. So from here you can see that the renal parenchymal function of the left kidney is already severely reduced. So we can call it a renal scarring on the, there's a decreased uptake or renal scarring on the left kidney. But otherwise, if you check a renal function test, there's still normal renal function test, because for our body, 1 kidney is enough to compensate our renal function mechanism. Then we go to a direct radionuclide cystography. The indication is for vesicle to assess a vesicular ureteric reflux. Usually patient come with the recurrent UTI or antenatally diagnosed to have a hydronephrosis kidney. So after the neonates or the infant 1 month or 2 months, usually they will assess on why this happened. So one of the possible cause is a vesicular ureteric reflux. So we use technetium 99M pertechnetate only. For this imaging, for this study, we put a patient with a CBD, with a continuous catheter bladder, continuous bladder catheter, and then we infuse 1 pint of normosaline which we already put technetium 99M inside it, and then the infusion we image the patient, and then you will see that the bladder, this is the bladder, you will see the bladder will fill up with the solution contain technetium 99M normal saline, and then until certain limit, then we will ask the patient to micturate, and then we change the tube into the bladder, into the urine bag, and then we will see if there is any reflux from the vesicular junction. So this is a normal scan. If there is a reflux, you will see like this. This is a right vesicular reflux up to the renal calyces. Okay, we go to the GIT, gastrointestinal tract. So this is one of the main procedure that we do in GIT, hepatobiliary scan. And the indication usually nowadays we used to rule out a biliary atresia. Okay, biliary atresia is the disease where there is no connection in the biliary tree. So for if you heard about neonatal jaundice, kuning, jaundice, yellowish discoloration of the face. So usually baby after delivery, usually they have this type of what we call neonatal jaundice. But if they persistent and increase in persistent of neonatal jaundice and increase in bilirubin level, so usually they will try to rule out if there is any biliary atresia. And sometimes they used to assess a bile leaking post operation and liver disease, but mostly nowadays we used to rule out biliary atresia. And the radiopharmaceutical that we use is a technetium 99M hepatobiliary immunodiacetic acid or HIDA, and the other derivative this HIDA mebrofenin. So these are the derivative of this study. So it will follow the what we call the physiological uptake of bilirubin into the liver. So if you see here, hepatobiliary scan, we inject the technetium 99M HIDA or this HIDA, and then we just simultaneously do the imaging, and then if you see here, there is a homogeneous uptake in the liver, and then later about 10 minutes, you will see the excretion of the bile of the radiotracer inside the biliary tree, and then you see a gallbladder at 16 minutes, and later at about 36 minutes you see the excretion inside the bowel. So if all the biliary tree are visualized and you see the excretion inside the bowel, this is a normal hepatobiliary scan, meaning that there is no biliary atresia or the biliary tree is patterned. Like this image, after 2 hours, 30 minutes, and 4 hours, up to 6 hours, you still didn't see the biliary tree and also excretion inside the bowel. So this neonates we suggest there's a biliary atresia in this patient. Okay, this is another example of to assess a bile leaking. So you see a bile leak from the usually after post operation we put a T-tube, and then there is a leak of a bile, then you will see a leaking of the bile inside the peritoneum. Okay, we go to medical scan. So medical scan is a gold standard to diagnose Merkel's diverticulum. Usually this type of disease happen in the pediatric age. Usually they come with abdominal pain and stool or cut blood positive, and then there is what we call anemic level of hemoglobin. So we want to see if there is any Merkel's diverticulum. Now, Merkel's diverticulum is ectopic gastric mucosa inside a diverticulum outside the stomach region. So we use a technetium pertanitate because technetium itself will go to the stomach. So physiologically it take by the stomach and excreted to the bladder. So if you see here, you see a uptake in the, when we inject the technetium 99M technetate, we see a uptake in the stomach, but we didn't see any uptake elsewhere in the abdomen. This is a bladder, the bottom one. So for the positive medical scan, usually we see the uptake in the right region of the abdomen. The uptake is usually similar uptake with the stomach. So this is a positive medical scan, and usually the surgeon will proceed to take out this diverticulum. And the last one for GIT, scan for GIT bleed. So for the scan for the GIT bleed, usually patient come with a chronic anemia, and then stool occult blood positive, or there's a melanic stool. So then we will find the cause of this chronic anemia. First and foremost, really for the medical, we will check for the blood functional full blood count and full blood picture throughout any thalassaemic disease, and also any iron deficiency or related to the blood itself, or any. And then if all normal, we will proceed with a scope, upper scope and lower scope, to see if there is any bleeding, and then maybe we'll proceed with CT scan to look for any mass in the GIT tract, and if still normal, then they will proceed with a CT angiogram, CT angiogram of the abdomen to see if there's any leak, and the last one, then we will do a scan for GIT bleed. So the scan for GIT bleed, we use a technetium 99M. We have to tag with the red blood cell of the patient. This pyrophosphate or stannous pyrophosphate that we use is the one that attach the technetium to the red blood cell. So in this, for example, in this image, you see a physical, when we inject this technetium 99M red blood cell, so we assume that all the red blood cell in our body will contain of technetium 99M, and then we can image if there is any bleeding. So you can see the physiological uptake in the, you see the arrow, physiological uptake in the heart, the upper bottom, the upper or image, and then you see the spleen and also the liver. And you see the arrow image, there is a bleeding in the right upper abdomen, and increase with intensity. So that's the location of bleeding. And there are three methods of labeling of RBC. First, in vitro, meaning that you just take out the blood, and then you tag with the ultratrack. Ultratrack is what called a stainless component, and then after we tag with ultratrack, then we inject to the patient and we scan. And the second one, we can do a in vivo technique, which is we inject the cold stainless first inside the body of the patient, and then after 20 minutes we inject the radioactive. So perhaps that when we inject the stainless, it will help the attach of the radiopharmaceutical inside the RBC. Or then, and the common methods that we do usually are modified in vitro, which is we inject the stainless pyrophosphate, and then after 20 minutes we extract the blood, and then we mix with the technetium 99M outside, and then later we inject back into the body. So there are three methods for labeling RBC. And the other example, active bleeding. For the active bleed scan, you see there is an increased bleeding in the right lower abdomen, suggests right colon bleeding. Okay, we go to the lung VQ scan. V is stand for ventilation, Q scan for perfusion. So this is a two procedure. So the indication usually we want to rule out a pulmonary embolism. Pulmonary embolism, there are what we call obstruction in the pulmonary vessel, in the pulmonary vessel. So usually patient come with a shortness of breath, and then patient must have some what we call comorbid history, such as obesity or bedridden, And also we usually can assess a chronic pulmonary embolism, and you also can use the VQ scan to quantify a lung volume if patient want to do a lobectomy. And the two procedure that we have to do is a ventilation. This ventilation type of procedure usually now in our the department we use a technique gas, which is the technetium we put in the what we call a modulator in the machine, and this technetium 19M will be simmer and become a gas we put, and this gas the patient will inhale this gas about 5 minutes, and then we put the patient on the machine on the modality and we image. So if you see here in the first image, the anterior ventilation, and the second image is a perfusion. So we have to compare between ventilation and perfusion. Perfusion, we just inject the patient with technetium 99M microaggregated albumin, and then we do the imaging. So should be the normal patient, the image should be the same, ventilation and perfusion study. But if there is a pulmonary embolism, the ventilation study should be normal because there is no obstruction in the ventilation, but there will be a what we call defect, which shape defect in the perfusion study. So if we have the image like this, we call a mismatch ventilation perfusion defect, which is the defect is in the perfusion. So it is a what we call the characteristic of pulmonary embolism. So the clinical indication usually when patient come with pulmonary embolism, they have to do the dimer, chest X-ray, ECG, and nowadays because of the uh, all hospital have the equipment of CT scan, so mostly patient will come with a pulmonary embolism, they will do a CT pulmonary angiogram, because the nuclear medicine facility is uh, not uh, not all state or hospital have this nuclear medicine facility. Okay, we go to the myocardial perfusion study. So myocardial perfusion imaging. So the indication you need to assess a myocardial infarction or myocardial ischemia, and also to assess a myocardial viability. And we do a SPECT or PET CT, PET image. So for the SPECT image, usually we use a technetium 99M maybe or tetrophosphine. Or for the PET, we use a fluoroethylene FDG. But I will show you only the SPECT image. So this technetium 99M cestamibor or tetraspamine, they will be uptake in the cardiac ward. So if you see here, this is the left ventricle image. So we cut the axial and we cut the vertical long axis and vertical what we call high horizontal long axis. I think it's quite difficult for you to understand, but the main thing that when we inject this radiopharmaceutical, they will go to the active myocardial scan, active myocardial tissue. So if there is any what we call this is normal. If there is any defect or reduce the tissue uptake, meaning that either it is infarct or ischemia. So like this one, if you see there is a defect at the anterior segment of the left ventricle, and also during rest anterior. So we do two what we call two procedure stress, meaning that when we stress the patient, either patient on a treadmill or we give a pharmacological stress test, and then we inject a redresser and we image because we want to see which part that having tissue that have a less uptake or no uptake, to measure the cardiac wall. So this is the type of infarct, because during stress and also rest, if the patient didn't do anything, just come to the department and we inject the tracer and we image. So if we have these two what we call two fixed defects, meaning that it's an infarction. So it will um, affect the management of this patient. So because it's infarct, usually they didn't proceed with any angiogram, but if it's ischemia, they will have to proceed urgently for to preserve the myocardial tissue. Okay, for thyroid scan, usually nowadays thyroid scan are seldomly done, but it still have what we call have some uh, beneficial if you want to do for especially to assess a solitary thyroid nodule. Now assessment of hypo or hypothyroidism. I mean nowadays for this assessment of hypo and hypothyroidism we use a thyroid assay, and then we also can assess the congenital or ectopic thyroid gland. And radiopharmaceutical that we can use in thyroid scan either technetium 99M patentinated itself because it go to the thyroid, or iodine 131 or iodine 123. Because all of this radiopharmaceutical will go to the thyroid. So I just show you some example of the thyroid scan or using a technetium 99M patentinated. So you see here there's a nice butterfly shape of the both thyroid gland, and this is the upper one is the marker, and the bottom one also a marker to make sure that we know where is the area of the thyroid itself, either inside the location or ectopic. And this is an example of the huge solitary thyroid gland, and you see here at the lower pole of the right thyroid gland there's a coalition meaning that there's decreased uptake. So the meaning of decreased uptake, that there is a chances of 20 to 30% of this core-lesion may represent malignancy or cancer. And also sometimes we see a hot lesion, meaning that they very increased uptake, meaning that there is a functional thyroid gland. And parathyroid scintigraphy or parathyroid scan, the indication is to rule out parathyroid adenoma in patients presented with hyperparathyroidism. And also sometimes you want to see if there is any ectopic parathyroid adenoma. And the methods, there are two methods, either we use a single tracer dual phase or we use a dual tracer subtraction. So single tracer meaning that we use either sestamibine or tetraspomine, and then only dual phase 15 and 2 hours. But dual tracer we use two type of radio tracer, and then we subtract the liver we subtract the thyroid, and it will, if there is any parathyroid adenoma, it will leave this only parathyroid adenoma. So if you see here, this is a single tracer dual phase. When we inject the technetium 99M sestamibine, and then you will see the increased uptake in the thyroid gland. And then after 2 hours, usually the thyroid gland will wash out. If there is any parathyroid adenoma, there will be increased uptake in the specific parathyroid adenoma. So this one is an example. You see that when you inject the technetium 99M sestamibine, there is a mild uptake in the both thyroid gland, and later you see there is an increased uptake at the upper pole of the left thyroid gland. So after 2 hours and 4 hours, it's remain increased uptake, meaning that this is a location of parathyroid adenoma. This is an example of dual tracer subtraction. First, we use a technetium 99M patentinated, and the uptake only at the thyroid. And later, after 3 hours, we use a technetium 99M sestamibine, and then sestamibine will go to the thyroid and also parathyroid adenoma. If there is present a parathyroid adenoma, then after we subtract the thyroid image from the technetium patentinated and technetium 99M sestamibine, then we get only the image of parathyroid adenoma. And sometimes the patient comes with hyperparathyroidism, the uptake in the thyroid is normal, but there is a ectopic uptake in the mediastinum to see a parathyroid adenoma. And then we go to neuroendocrine tumor. next tumor, neuroendocrine tumor, and adrenal gland tumor, such as pheochromocytoma. So mostly in this disease, we have a lot of what we call radiopharmaceutical that can be used to detect the neck tumor. And the previous radiopharmaceutical that usually we use is iodine 131 or iodine 123 MIBG and indium 111 or trotype. But the latest for neuroendocrine tumor, usually they use a gallium-68 DOTA peptides or somatostatin receptor or fluorine-18 FDOPA. So this gallium-68 and fluorine-18 are what we call PET emitter, but iodine and indium are what we call the SPECT emitter, the normal gamma ray emitter. So this different instrument that we have to use to detect the radioactive from both radiopharmaceutical. Because example, if we use iodine 131 MIBG for adrenal scan to look for pheochromocytoma, you see there is increased uptake in the adrenal gland. We show that there is what we call pheochromocytoma, the adrenal gland tumor. So patient and then the endocrinologist and the surgeon then can remove the lesion. And before last, we have a positron emission tomography, a computed tomography, or PET-CT. If you go to nowadays, if you go to the ward sometimes, or if you go to the Department of Nuclear Medicine, this is most popular because it reflect the nowadays we use in oncology imaging. So it is a hybrid imaging, meaning in one modality, they combine a PET tomography and also compute tomography. They have two machines inside one machine, what you call hybrid imaging. So the PET emission tomography are more focused on functional or metabolic activity, and the compute tomography are more focused on anatomical localization. So the common radiopharmaceutical for PET positron emission is a F18 or fluorine-18 FDG, and nowadays for the prostate and also neuroendocrine tumor, they use a gallium-68 DOTA or gallium-68 PSMA. But I will show you more on fluorine-18 FDG. Okay, like I said, the fluorine-18 FDG, fluorodeoxyglucose, it will mimic the glucose metabolism. So for the oncology imaging, the theory behind it is because the cancer have the ability to multiply 4 to 8 times more compared to a normal tissue. So we use the metabolic glucose metabolism to detect if there is any increased uptake in the cancer cell. So the indication usually mostly we do for oncology, and then sometimes we can use for myocardial perfusion imaging, neurological imaging, and planning for radiotherapy. And the patient preparation is different between the SPECT and PET imaging. So you can Google or you can look in the website how they prepare for the fluorine-18 FDG patient, because it is very important that you know the patient preparation to avoid what we call false positive result, because it will follow a metabolic or glucose uptake. So there are certain activities, certain things that the patient must follow to make sure that the false positive result can be reduced. So you just fine, and I will share to you later. This is the image of the PET-CT image, and if you see the first image, there is a metabolic. The PET image is a metabolic, or it will detect a functional unit, functional imaging. In that, all the glucose uptake you can see here. You can see the brain uptake because it's used more utilized glucose. The heart utilized, and then the excretion in the bladder. And then the second image, the middle one is a CT. CT will show you a good anatomical localization. So when we combine both PET and CT, we call fusion image. So we can see both anatomical and also metabolic activity. So we increase the sensitivity and also specificity of the image. And then okay, I think this is the last one. It's a iodine 131 whole body scan post therapy for thyroid CA. So patient usually come with thyroid carcinoma, and then surgeon will do a total thyroidectomy. They remove all the thyroid, and then after that they will send to iodine 131 whole body scan to see if there is any remaining thyroid tissue in the neck or elsewhere in the body. So usually when we use iodine 131, we give it to the patient orally, and then we image after 3 days, and then you will see here this is a physiological uptake in the thyroid gland, physiological uptake in the salivary gland, and then because we give orally, you can see a stomach, colon, and bladder. And if there is any metastatic thyroid carcinoma, usually you will see that increased uptake in the like this one, metastatic to the lung. So previous image you can see all the form like a body or hand, but this one because they're very intense uptake in the lung, so you didn't see the the area of the body itself. So this is the what we call the some of the general post-procedure precaution to avoid contact with a public, especially children and pregnant lady, at least after 10 half-life of the tracer, and drink a lot of water. And some of the therapeutic precaution, maybe they need to stay longer in the ward. Okay, thank you very much. So hopefully we can have some idea regarding the use of radiopharmaceutical in the study. So this is the important why the pharmacists have to know the how the radiopharmaceutical act, because different radiopharmaceutical different pharmaceutical product will give a different uh, organ localization and organ uptake, and usually all the pharmaceutical product or the carrier or the call kit that we use to bring this technetium 99M depending on the physiological uptake of that organ. So hopefully this is for sharing. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.